very eminent speakers from different parts of the world. So I'm happy that all of them, they are participate and they accept our invitation. I will just give a mic for everyone just in 1 second or 3 seconds for everyone to give his full little introduction about himself. I will start with the farthest area, Dr. Qudayh, so because he's in the top of the here in the okay, Dr. Qudayh, please, if you introduce yourself, so to the participants, I know.
Qudayh or Gidey. I live in Winnipeg, Manitoba. The time right now is 11:06 a.m. and I practice ophthalmology, mainly in the area of cataract surgery, refractive surgery, and glaucoma. And I'm very happy to join this nice group.
Thank you, Dr. Qudayh. Thanks a lot. Dr. Sandeep.
Yeah, I'm Dr. Sandeep Mitra. I work in Dubai, Sharjah, mainly. Basically a cornea, refractive, and cataract surgeon. That's all about me. Thank you.
Thank you, Dr. Sandeep. Dr. Osama.
Hi, good evening, everyone. Osama Jaledi, Morphy Eye Hospital, cornea, refractive, and cataract. And we're looking forward for the meeting.
Thanks, Osama. Dr. Dibak. So I'm moving according to the picture in front of me.
Yeah, hi, this is Dr. Deepak Sharma. I am a cornea, cataract, and refractive surgeon, presently working in NMC Healthcare in Dubai. And it's a privilege to be part of this wonderful forum today. Thank you.
My dear friend, Dr. Muhammad Husni.
Hello, everyone. My name is Muhammad Hosni. I'm a professor of ophthalmology at Cairo University. I'm mainly a cornea guy, so I work in cornea, refractive surgery, and anterior segment, including cataracts, of course.
Dr. Ali, just mute mute. You are now mute, so unmute yourself. So, Dr. Ali Al-Rajihi.
I'm based, Ali Al-Rajihi, based in Riyadh, Saudi Arabia, doing the same almost cornea, refractive, and cataract surgery.
He is the father and of all refractive in Saudi Arabia, the king of refractive in Saudi Arabia, king in the kingdom. And my dear also friend, Dr. Fogla.
Hi, everybody. I'm Rajesh Fogla, based in Hyderabad, India, working at Apollo Hospitals. I'm basically an anterior segment surgeon, specializing in cornea, cataract, and refractive surgery.
Thank you for all of you. We are still only missing Dr. Mazen Sinjab, who will join us in a while, in a short time. So without any delay further, we are going to start with the first talks. It will be a role of cyclosporine in ophthalmology theory into practice. It will be by Dr. Deepak Sharma for about 15 minutes, please. Yes, can you just unmute yourself, Dr. Deepak, and share your screen, please.
Is my screen visible?
No. Yes.
Is it visible now, sir?
Yes, yes. Go ahead, please.
Yeah. Good evening, everyone. I'll be speaking about the role and indication of cyclosporine in our field. So cyclosporine is a cyclic undecapeptide produced by the fermentation of two fungi, Tolypocladium inflatum and Beauveria nevus. So as far as the mechanism of action is concerned, it involves the formation of a complex cyclosporine and cyclophilin, which blocks the function of the enzyme calcineurin serine phosphatase. That starts a cascade of events, eventually leading to the prevention of interleukin-2 production, which then inhibits the activation of the T cells. So apart from the reduction of the activated T cell lymphocytes, the cyclosporine also causes reduction in the levels of the markers of apoptosis. It causes reduction in the levels of pro-inflammatory cytokines. There is also a normalizing impact on the squamous cell metaplastic changes that are happening in conjunctival epithelium in patients with inflammatory dry eye. And the cyclosporine is also known to increase the goblet cell density, thus facilitating the mucil production, which is an integral part of the tear film. Now, there are various indications of cyclosporine in ophthalmology, most of them being off-label. The only FDA-approved indication is dry eye. Dry eye, we all know, is a complex theory, involving inflammatory cascades leading to damage to the ocular surface, mediated by neurogenic inflammation, leading to changes in the osmolarity of the tears. The various autoimmune diseases are also implicated and known to cause dry eye. The whole process seems to be mediated by T cells, thus inducing a form of white inflammation on the ocular surface. So dry eye is not the function of only quantity of tears as was previously thought. It is now considered a disease of abnormal tear composition. So that is the quality of the tears that is the main issue. So as far as cyclosporine is concerned, multiple clinical trials have proven that cyclosporine 0.05% results in a reduction in corneal punctate staining, increase in tear production, improvement in the symptomatology of the patients, and decreased dependence on the supplemental artificial tears. Next indication would be patients with vernal keratoconjunctivitis. Several studies have explored topical cyclosporine as an alternative therapy for such patients with VKC and have yielded positive results. In fact, typical improvement was noted to have occurred after a QID therapy with 1% or 2% cyclosporine in oil solvents. However, studies have also shown lower concentration like 0.1 and 0.05% to be working in VKC because they claim that its emulsion vehicle helps to actually impart greater efficacy than expected for a drug concentration of 0.05%. So they found that topical cyclosporine in various concentration can help to reduce corticosteroid usage and is an effective and safe option for the treatment of VKC. Moving on to the next indication, that is atopic keratoconjunctivitis. It's a very severe inflammatory ocular condition that has the potential to cause severe corneal complication and resulting in irreversible vision loss. Corticosteroids are definitely the mainstay of treatment in AKC, but the use of topical cyclosporine in various studies have been shown as either alone or in combination with the topical steroids to be beneficial in those trials. Next indication is the use of cyclosporine in patients with SLK. The superior limbic keratoconjunctivitis is a recurrent disturbance of the superficial palpebral and bulbar conjunctiva as well as of the limbal cornea. Multiple treatments have been used, varying from milder interventions like lubrication and BCLs to more invasive like chemocautery or surgical resections. However, a study published in 2003 in Ophthalmology where Perry et al. Concluded that a 0.5% cyclosporine eye drop used 4 times daily caused improvement in the signs and symptoms of such patients. There were improvement in the irritation and foreign body sensation and the filamentary keratitis. They concluded that topical cyclosporine may be useful as a primary or as an adjunct therapy for such patients. Next, most common condition we all come across in our daily practice is the subepithelial infiltrates post-adenoviral, and 0.05 or 0.1% cyclosporine is known to be safe and effective alternative treatment in patients with subepithelial infiltrates. Studies have also utilized higher concentrations as steroid-sparing agents in patients with steroid responders. Moving on to the next indication of superficial punctate keratitis, topical cyclosporine has been used effectively and safely for the treatment of these patients, and it is documented to be useful in selective cases where topical steroid fail, or in patients where there is high risk of complication following long-term steroid treatment. Various studies have used concentrations varying from 0.5% to 2% and reported success by those groups. Another important pathology are the patients with Murray's ulcer. It's a chronic ulceration of the cornea having an autoimmune etiology. Study published in Cornea in 2008, where RPC group from India has concluded that topical 2% cyclosporine can be safe and useful adjunct to standard medical therapy in patients with recalcitrant cases of Murray's ulcer. However, it is important to note that it is the systemic use of immunomodulators which holds the key to prevent relapses and control the inflammation in this disease entity. Another important indication for cyclosporine would be patients with MGD and posterior blepharitis. A study published in Cornea in 2006, where Perry et al. Concluded that cyclosporine-treated patients had significantly fewer meibomian gland inclusions after 3 months as compared to artificial tears. They showed reduction in vascular injection, and the Lissamin green staining of the conjunctiva also improved. They also reported that the mean corneal fluorescein staining score actually decreased by more than 50%, thus improving the TBUT score. Next indication would be the patients with ocular rosacea. It's a severe inflammatory condition that is associated with all the features of chronic dry eye. And a study published in International Journal of Ophthalmology in 2015 concluded that 0.5% cyclosporine treated patients actually showed improvements from baseline in their corneal staining and TBUT times, and the Sharma scores were also significantly better. Another study showed that the topical cyclosporine, when compared with the oral doxycycline, was equal or better in treating such patients when we are looking at the long-term side effects of using oral doxycycline. Another indication are the patients with the LASIK-associated dry eye. A study published in JCRS in 2006 showed that 0.05% cyclosporine-treated patients had significantly better Sharma scores, and the mean refractive spherical equivalent was closer to the intended target at 3 and 6 months post-surgery in the cyclosporine-treated patients. Next indication are the patients with contact lens intolerance. A study published in Eye and Contact Lens in 2006, they mentioned about a 5-week randomized study of 17 patients who self-reported contact lens related dryness symptoms, and they were randomized to cyclosporine twice per day and rewetting drops twice per day to be used before and after lens wear. Changes from the baseline in fluorescein staining of the cornea and conjunctiva were used to determine dry eye signs, and after 5 weeks of cyclosporine treatment, they concluded that there was significant improvement in the dry eye symptoms. The patients had better contact lens wearing time, which was increased per day. There was, however, no significant difference in the mean corneal staining between the two groups. However, after 5 weeks, the cyclosporine treated patients showed statistically better improvements in temporal bulbar conjunctival fluorescein staining as compared to the patients using rewetting drops. Next indication would be the patients with corneal graft rejection. In 2003, Kosser et al. Reported that combined treatment with 2% topical cyclosporine and topical corticosteroids was more effective at preventing corneal graft rejection episodes in pediatric patients in comparison to corticosteroid alone. However, subsequently, two studies, two trials published in 2008 and 2010, which involved 151 subjects. They used topical cyclosporine 2% in one and 0.05% in the other for a period of 6 months. And both trials actually concluded that there was no advantage of adding cyclosporine to steroids in patients with graft rejections and patients with previous history of graft rejection. And they concluded that as far as this group of patients are concerned, steroids still holds the key. Next indication would be the patient based on the study published in the form of 2 RCTs, which compared the effect of cyclosporine versus placebo in improving the corneal sensations postoperatively. So one group was after LASIK and the other group was after cataract surgery. The corneal sensation were measured with aesthesiometer in the different multiple points in the central and the peripheral cornea. And the concentration of topical cyclosporine used was 0.05%. The treatment duration was 1 month and 3 months respectively. And both the studies actually concluded that cyclosporine was effective in hastening the recovery of corneal sensation post-op. Last but not the least is the role of cyclosporine in keratoconus. We all know that the tears of keratoconus patients have elevated MMP9 and inflammatory cytokine levels, and cyclosporine is known to reduce MMP9 and the levels of these cytokines in an in vitro inflammation model systems. So a study published in IOVS concluded that in keratoconus patients, cyclosporine treatment by reducing the MMP9 level in the tears also caused concomitant arrest of the disease progression, which they documented topographically. So cyclosporine might be a novel treatment strategy in the future for KC patients, but definitely requires additional evaluation in larger studies. Now, a typical case scenario where a 50-year-old female presents to us with dryness and burning sensation in both eyes, a known case of rheumatoid arthritis in 6 years, on medication, best corrected visual acuity of 6/9, Shermer score 5 and 4, with TBUT scores of 4 and 5 seconds, and presence of inferior corneal staining. After a pulse therapy with topical corticosteroids, she was put on restasis 0.05% and lubricating drops. The treatment was continued for 3 months. Shermer scores improved to 8. TBUT also improved, and the corneal staining appeared much better, resulting in a happy patient. Another 40-year-old male patient complaining of dryness and foreign body sensation in both eyes, known case of SGS since 2 years, on medication, best corrected visual acuity 6/9, parts at 6/9, lower Shermer scores and TBUT with inferior corneal staining. After a pulse therapy of 2 weeks with topical corticosteroids was maintained on restasis 0.05 and sodium hyaluronate eye drops. A treatment was continued for a little longer, a period of 6 months, leading to better Shermer scores, TBUT improved, and corneal staining also appeared better, resulting in another happy patient. Now, there is a problem with cyclosporine, and that is its hydrophobic nature, which as a molecule presents a challenge in developing an effective ophthalmic formulation. Because poor water solubility would mean that the aqueous solutions at clinically useful concentrations are likely to be unstable. So to overcome these challenges, cyclosporine was prepared in various forms of oils like castor and corn oils, but localized side effects such as burning and redness and itching, epithelial keratitis, they all limit the use of such vehicles. So to enhance the delivery of cyclosporine, emulsion formulation was introduced in the form of restasis. However, the improvement in the drug delivery still continues in the future, because the idea is to improve drug penetration and enhance retention time, while at the same time we need to reduce the side effects of such as stinging. So researchers are coming up with novel formulations of cyclosporine solutions such as gel systems, the nanoparticles, the cationic emulsions, the myceles, solid devices such as shields and collagen implants, which are directly administered subconjunctivally or intravitreally in order to enhance the CSA concentrations in the vitreous. Now, as far as the systemic side effects are concerned, extremely low blood concentration has been reported of cyclosporine after topical administration, and systemic side effects and non-ocular treatment-related adverse effects were not observed in clinical trials of these ophthalmic emulsions. So the take-home message would be that cyclosporine has a definite role in plethora of conditions as off-label medication with excellent results. Different groups in the literature have used variable cyclosporine concentration and reported successful responses to the clinical entities. We need to be very patient when we are waiting for the response when treating a patient with cyclosporine. And we need to consider cyclosporine as a valuable molecule in our drug armamentarium when one needs to look beyond steroids and where long-term treatment with steroid is being contemplated. And to conclude, the success of cyclosporine on various ocular conditions indicates that dry eye represents only just the tip of the iceberg as far as the potential of this drug is concerned in ophthalmic care, because every now and then we all encounter an unusual patient who fails to respond to conventional therapies. So awareness of this drug's ability is essential in providing these patients with the best possible outcome. Thank you so much. Thank you.
Thank you very much, Dr. Deepak, for this very comprehensive and about a new also information about the indication of using cyclosporine. We have one raised hand, but before we go to that, I need only a small comment, maybe from any one of the colleagues, especially about the using of the cyclosporine in a patient with keratoconus. For me, it's something first time I'm hearing about, to be honest. Anyone have any experience or any information about that to comment? Dr. Mazen, anyone? Dr. Fogla, Dr. Osama, Dr. Muhammad?
Sometimes you can have keratoconus which are associated with allergic eye disease, wherein you for acute episodes you manage them with topical steroids, but then to sustain the effect and to reduce the allergy and to minimize surface inflammation, maybe topical cyclosporine may have a role in that aspect, because with the persistent surface inflammation, it may have some role in the progression of keratoconus. That's what people are trying to research and look at it, because primarily keratoconus is a non-inflammatory condition of the cornea, but it can be associated with allergic eye disease.
And recently, it has been shown that rubbing the eye does contribute to the amount of keratoconus. So Gattinell's theory about no rub, no cone. Definitely, if you're using cyclosporine to limit the amount of ocular surface disease and the ocular surface inflammation, I think this would benefit. This would serve well these patients with keratoconus.
But as I get to know from, sorry, Dr. Osama, to get to know from Deepak, according to what he mentioned, that's in the pathology itself of the keratoconus, there is some part of inflammation that they are trying to treat. That's what I understand. Is right, Dr. Deepak? Or
yeah, sir. In that study that was published in IOVS, they actually studied the level of MMP9 in the tears of the keratoconus patients, and they then correlated that by using cyclosporine to reduce the levels of the MMP9, and then related with the changes happening in the topography of those patients, where they actually showed that the progression was not happening or it was reduced based on the keratometric values. So, but however, the study was on fewer subjects. So they concluded that we needed a larger cohorts to finally reach to an outcome and document the role in actually preventing the progression, whether it has a role or not.
Yeah,
thank you very much. Thank you.
I think I'm aware with this about this study, and I don't think this study the conclusion was correct that I know that there are many theories now that say that keratoconus has an inflammatory component, but I think these patients that were included in this study just had an associated sort of vernal keratoconjunctivitis of a sort. But having said that, is cyclosporine the treatment of choice in these patients, even for steroid-sparing reason? Or would we go for something like tacrolimus, or I don't know. I mean, in these patients in specific, I think cyclosporine, especially if we're using Restasis, which is a 0.05%, I think will be a very weak drug to limit the inflammation. The other thing is the MMP9, it's either there or not there. They cannot actually gauge the amount of MMP9 because there's only one test, which is the inflammatory, and it tells you if the patient has a high level or does not have a high level. It doesn't give you a specific, improvement in the MMP9 levels in these patients. So I think there are a lot of comments or remarks on the results of this study, but definitely the association of ocular surface inflammation with keratoconus is very well established.
Now, may I have a comment, Dr. Muhammad?
Yes.
Dr. Muhammad, yes. Thank you very much, and I'm sorry for joining late. However, I agree, totally agree that there is an inflammatory process in keratoconus. Some studies are about this. In addition, people with keratoconus, they suffer more than others from dryness because of the irregular pattern of the cornea and the irregular pattern of the tear film coating the cornea. So these are two reasons to use the cyclosporine. Now, I'd like to share my experience in cyclosporine. I used to formulate the cyclosporine to be 0.1% with castor oil. We used to prepare these drops and give those drops to those patients and other patients suffering from chronic allergic keratoconjunctivitis or conjunctivitis. And actually the 0.1% cyclosporine with castor oil was perfect in beating rubbing of the eye and beating the inflammatory process. So, but actually I didn't have sufficient number of patients of keratoconus to conduct a study. So maybe with the colleagues, we can conduct a study about using this percentage with the castor oil.
Now we have been using cyclosporine 0.1%, and we have been doing it in-house back in the day. I think this was when I was a resident back in 1994 or something. We used to do this as a standard thing, but we didn't use castor oil. We actually used olive oil at the time when we were residents at the university. And the thing that I knew, which was very funny and which was interesting, is that we used to make like the fortified eye drops, the antibiotic eye drops. We used to do it inside the department. And the thing that I learned at the time, it is a small fun fact actually, that when we used to get olive oil from the pharmacies, we were told that the olive oil grade in coming from the pharmacy that, for example, is used as a hair supplement or something, this olive oil is not as pure as the olive oil that we use in food. So we actually went to the supermarket instead of going to the pharmacy, and this was the high grade olive oil that we used at the time, and we used to do sterilization, and we did the 0.1. And the 0.1 was very, very good in controlling ocular surface inflammation. And surprisingly enough, we used it in high risk keratoplasty cases after we did the graft. So this is just a fun fact that I remembered when Dr. Mazen.
Thank you, Dr. Muhammad. Dr. Osama?
Basically, it's one thing suggest, I think the dose, you can increase it for these cases, vernal and other cases. You should use it, you can use it 4 times a day instead of twice a day for refer to Restasis. I think Restasis is weaker, but I think you could improve the dose by increase it 4 times a day instead of twice a day, which we do for dry eye.
Okay, we have several questions. If we can just have a very short answer, because not to lose the time, already 5 minutes above the our time. Can we use cyclosporine in moderate to severe cases of vernal keratoconjunctivitis? This is the first questions.
Yes, of course we can.
Okay, there is another question. Experience with cyclosporine, have you faced any annoying local side effect, and what was your approach and alternative to cyclosporine, especially for dry eye disease? Anyone have an answer to that?
Well, actually, cyclosporine doesn't have much of, in any formulation, we have not experienced a lot of side effects. Even when we use it in sometimes in an ointment form, we get Icurvis from the UK, and we didn't find, the thing that we found is when we used tacrolimus ointment, protopic, which is a skin ointment. Sometimes we use it for vernal keratoconjunctivitis, and this ointment does cause a lot of stinging, burning, and sometimes redness in the eye.
Okay, there is another question is if we can use this one in children, how long we can use in children for vernal keratoconjunctivitis? You know, it's a disease that
you can use it. There's no restriction for children. But going back to tacrolimus, because last time I went to India.
But I mean, Osama, can you just about the children? I mean, how long? I mean,
depends on the disease. Depends on the disease condition. You need to quieten the eyes. You don't want to end it with corneal scars for these children. So it's very important to control
that's why I'm insisting to have a proper answer about this one, because you cannot continue like what you are giving antihistamine and sodium hyaluronate that or to stabilize the muscles. Here you can use for a short period, then after that, if not a continuous, right?
No, but it depends on the disease. Maybe can you use it for a few years, really?
Okay.
One thing about tacrolimus, in India, they have ophthalmic tacrolimus. I'm not sure, Dr. Fogla, if you comment about that, how is the experience with tacrolimus ointment from India?
Oh, yes, we have Indian companies manufacturing tacrolimus ointment for ophthalmic use, which is quite good. Does cause a little bit of stinging, but we apply only once at bedtime and seems to work very well. If it is not available, you can use the skin ointment, but instead of a direct application into the eye, you can ask the patient to apply it on top of the eyelid, and it does penetrate through the skin and has an ophthalmic effect as well, and does not result in any kind of ophthalmic stinging. But the only thing is, if you use it for a prolonged period of time on the skin on the eyelid, sometimes you can get depigmentation of the skin, so you need to watch out for that. So you use it only for a duration that it's really required. So the acute episode we control with steroid, use cyclosporine or tacrolimus to maintain the the disease. And once the disease has quietened down, I think lubricants become the mainstay of treatment, and we try to find out what are the allergic factors that incite the disease and try to minimize exposure to that. And this has a seasonal variation. So whenever the symptoms flare up, we again restart. But we don't continue with that on a very long period of time. I think once the disease is under control, lubricants and maybe mast cell stabilizers are the mainstay of treatment.
Okay. Thank you, Dr. Fogla. We are having 2 raised hands. So for Dr. Farzad, Mr. John, if you can open for Dr. Farzad and Dr. Sumit Sukhai. So anyone is there, please. We have a question before till we get how do we change the concentration of cyclosporine? I mean, we are having the one we are using is a fixed dose that we know it's a concentration. How we can change? Dr. Mazen and Dr. Muhammad, I think you talk about this one. Yes, or Osama, yes.
Yeah, actually, there are special formulations for that, for preparation. And this should be, of course, either in the OT or by pharmacy. There is a book published about the formulations of extemporaneous ophthalmic formulations. It is available in the market, and it includes more than 100 medications. One of them is the different concentrations of the cyclosporine. So I advise everyone to read this part of this chapter.
Not to buy the book.
Yeah, just to read.
Okay, good. Okay. There is another things before we get anyone is there from yeah, Dr. Somit here. Can you open for Dr. Farzad or Somit to ask the question, please? Dr. Farzad.
Is not here.
Okay,
Dr.
Somit.
Dr. Sumit is here.
Okay, please open for Somit. Somit, Dr. Somit, if you want to, you are
Hi,
now, right?
hello, hi.
Yeah, hello, Dr. Somit.
Hi, Dr. Amri, I just want to ask the same question which I had typed actually, that how do we change for practical purposes if we want to increase the concentration of the yeast? Because right now what we have is the restasis that's fixed.
Okay.
So how do we change in some situations we need it to go to 0.1%, sometimes even 1%. So how do we do that? How does a general ophthalmologist do that? This is what my question was.
Without
cannot.
the need to buy the book, I think you can find it online. We used to have like a piece of paper that explained exactly how to do this. And when we used to formulate it, we used Sandimune, which is the cyclosporine tablets. And we used to dissolve it either in olive oil or in castor oil. And there was a special formula with each and every concentration. We had concentrations up to 2%, how to do the eye drops. And I don't think it's rocket science. It has been there since more than 20 years. And it's very easy to find.
The only thing you cannot take.
Can you modify the drug itself? Okay, Osama, sorry.
You cannot increase the concentration. You can dilute the concentration. So don't expect the restasis you're going to make it higher concentration.
No.
You dilute it.
No. You can do it up to 2%.
No. But what I mean, you cannot make the restasis
the already one
higher
available.
concentration.
Yes.
So you dilute things not to concentrate in it.
You can actually boil it, Dr. Osama, and then some water will evaporate.
But
Okay,
you can use
this
it
is very
more.
good,
But
Dr.
what you
Muhammad.
can do, you can use more restasis. You can increase the frequency. So can you use the restasis 4 times a day? That give you
Yes.
slightly more dose.
Okay. Osama, if we increase the dose, I mean the frequency, it will increase the concentration.
It will help.
It will help.
It
will help more. Okay. Okay. Before we move to our next session, actually, which is a panel discussion about corneal comorbidities with doing a cataract surgery, I have only the last question, maybe about this one. As all here are cataract and refractive surgeon, what is the role of exactly of cyclosporine in a patient after refractive surgery or after cataract surgery? I will start now with Sandeep. Sandeep here with us. So Sandeep didn't participate with us. I don't know. Dr. Qudeh. So Sandeep and Qudeh, this question for both of you. So cataract. I think, yeah, go ahead, Sandeep.
Yeah, just one comment I wanted to make about Deepak's study, which he was talking about, which was done in Australia. In fact, I actually participated in that study when I was there. The concentration of cyclosporine used for corneal graft rejection, and they used 2% and 0.5%, and we didn't find any significant difference in both these percentages, and there was no, it was not better than the conventional steroid therapy. The problem is if you increase cyclosporine to higher concentration, it does cause epithelial toxicity, and there were cases where we had noticed a lot of epithelial erosions, and that's why we went ahead and started decreasing the concentration and went back to 0.5. So that's one thing is there. For my cases of refractive surgery, I do lots of smile procedures. So dry eye, at least in my case, the dry eyes are less. I don't use cyclosporine in these patients. But
in general, because you are not only doing any smile, you are doing also other procedures. So how do you feel to the benefit of using cyclosporine?
Yeah, so even for LASIK patients who are resistant to lots of these combinations of topical lubricants, I think cyclosporine does help them. And many times we have found that we are actually, when we add cyclosporine in these patients, the amount of lubricant which they are using tends to go down. So after you start the patients on cyclosporine, not only that their symptoms improve, also the frequency of drops also decreases with time. So it really works well with refractive patients, and they do well.
Thank you, Dr. Sandeep. Dr. Qudeh, about the post-cataract surgery, you have any experience to use? Because already Dr. Deepak also mentioned that we can also now, and there is a lot of talk about now to use cyclosporine after cataract surgery.
Yeah, when doing a cataract surgery, whether it's whether we're going to put a premium lens in or even a regular lens in, or doing a refractive procedure, I think keeping in the back of your head that the dry eye issue can be a limiting factor to their best corrected acuity. So therefore, I do not allow a premium lens to go in until we get the dry eye addressed. So that could, like I used Xydra more than Restasis. I don't know if you guys have experience with Xydra, but I found it a bit better than Restasis in dealing with this, and also shortens the mechanism of action comes faster than Restasis. So I find people feel their dryness is better sooner than what Restasis can do.
I think yeah. With the weather, because I've used Lifitegrast since it came out. It was in a hype like a couple of years ago, and we imported some of them, and we started using Lifitegrast. But the thing that I definitely noticed that the effect of Restasis was much more. Restasis was much more effective than Lifitegrast in our part of the world. I'm not sure if this is maybe the immunological synapse is more in the cold weather than in the warm weather. I'm not sure, Dr. Gudi, but really I think that Restasis is much more effective than Lifitegrast in my practice in Egypt.
Muhammad?
Yeah, thank you. Yes.
I have comments that have not been mentioned regarding.
Yeah, Dr. Ali. Yes, Dr. Ali, go ahead. Sorry.
Regarding cyclosporine topical, we have a lot of Vernal in Saudi Arabia, and the problem with Vernal, once you start with cyclosporine, once you stop it, there is a relapse. So you need always to repeat it and repeat it again.
For how long that you can go, Dr. Ali? Because this another question is
4 months sometimes. Huh? And as you know, it peaks during the summer.
The summer seasonal, yeah.
Once you have the winter, then it will subside. And regarding the rejection, especially in high-risk patients after multiple penetrating keratoplasty, I found topical is not as effective as systemic. And this is why sometimes we use systemic cyclosporine, 3 to 5 milligram per kilogram, for 6 months, minimum of 6 months. And we found that patients respond very well and they have less rejection rate. And the third thing regarding use of cyclosporine, like Restasis, sometimes we use it especially after refractive or dry eyes for those group of patients who have dry eyes related to inflammation, and they might have response. Not on all patients, but there are certain groups of patients who might respond if it is associated with some inflammation.
Thank you, Dr. Ali. Actually, we have a lot of things to talk about the cyclosporine and the effect, and I think Deepak, he have passed through most of it, and he gave us up to a lot of information and about the studies that's going on. Away from the what's approved to be used in cyclosporine. Thank you for all about this one, and we can go now to our second session. This is very interesting, and it will be, I think, a lot of discussion about this one. And we can start. Our session here is the cataract in corneal comorbidities, and we are having many corneal comorbidities when we are doing a cataract surgery. We will start with there is a lot of them. We can go through of them very fast, but we can select few of them faster than other. Maybe dry eye, we can keep it for a little bit later. We can start with, we can start first with cataract with history of herpes simplex virus or herpes zoster keratitis. So I can give this question to Dr. Qudeh. I think he was talking to us his experience with dealing with a patient they are having a history of herpes simplex? Dr. Qadeh.
Yeah, so basically, what I have been doing is that making sure that they have been stable and no recurrence in the last 6 months before considering cataract surgery. And also, I mean, you know, there are things that we have to think prior to the surgery, and then things that we think about during the procedure, and then after the procedure. So if someone has an old scar that hasn't been active for years and all, you just basically going to be, you know, during the procedure that I do use, you know, vision blue for these patients, because staining the capsule for a good rhexis would be a good thing. It will. Now, before going to cataract surgery alone, if these people benefit from a triple procedure, like a corneal transplant and IOL replacement, lens replacement, then I would get a cornea specialist involved into this. But if I'm doing the surgery for one of my uveitic glaucoma patients who had a scar, I would, you know, for the safety of the procedure, I would use vision blue. I will watch them carefully. I try to drop the NSAIDs drops, you know, post surgery, and then also watch because there's a majority of my patients are glaucoma patients too. So having the keeping in mind the use of prostaglandin in their activation to herpetic eye disease is something I always keep in mind and think about it, and try to avoid as possible, and then watch them carefully in the post-operative period. And yeah, that's
okay. Dr. Qadeh. Now, Osama, if you are with me, so we are moderating this session together, me and Dr. Osama. If you can to ask for anyone.
Do you give them the systemic prophylactic, cyclosporine or Valtrax?
Yeah, we do keep we do keep them on Fanvare, you know, like a 500 twice a day.
For how long, Doctor? Sorry, Osama.
Well, you know, you know, just to be honest, I don't usually I don't have those patients as my primary. Like here in Canada, we do share patients, so I'm not the one who arrange their regimen, but I know they do stay on a prophylactic dose for to prevent the recurrent eye disease.
Okay, who is having from our colleagues here any idea about the regimen for that? If you can give a prophylaxis regimen, as Dr. Osama mentioned.
Yeah,
Dr. Ali, Dr. Mazen.
I'll make it as a question to all. Now, one of the protocols is first, the eye should be quiet for at least 6 months. Then we start systemic antiviral for 1 week before the cataract surgery. And then we keep the patient on the systemic antiviral after the cataract surgery for about 3 to 6 months. Now, this is one of the regimen. So
3 to 6 months, you are keeping the patient on antiviral tablets, you mean?
Yes, tablets. This is one of the regimen. So my question is to expertise people like Dr. Ali Rajhi, Dr. Osama, whether and others. I think. Yeah. Fogla, yes, of course, Deepak. So please, can you comment on this regimen?
Well, for cataract patients, if they are free from herpes, I don't usually give them any prophylaxis. For corneal transplants, I usually give them prophylactic preoperatively and continue for even sometimes years. I have patients with Valtrax for valcyclovir for years, and it is very well tolerable drug. So not for cataract. I mean, if they have any episode, it's easy. It can be managed and treated.
You mean, Dr. Ali, what time, how long you will keep? For example, if the patient have an episode of herpes simplex and it was active, then he was having a cataract, how long you will keep him free and stable till you start doing the surgery without any regimen?
I wouldn't stay for 6 months, maybe less, 3 months. It depends how frequent this herpetic keratitis comes to that patient. If it is infrequent, then I go ahead. If it is frequent, then I stay away for at least 3 months.
3 months. Okay. Any other suggestion or any other experience, Dr. Fogla? Maybe I can hear Dr. Fogla here.
I agree with most of the points that's been made. You have to differentiate between doing a corneal transplant in an eye with prior herpetic disease versus doing a cataract surgery. So a cataract surgery, does not involve prolonged use of steroids as well. But if I do have a patient with prior history of herpetic eye disease, I want the eye to be quiet at least for 3 to 6 months prior to doing the cataract surgery. And I do put them on oral antiviral prophylaxis, at least for the duration while they are using topical steroids. And after they have stopped topical steroids, so I may not continue it for 6 months, but at least for 2 to 3 months, I would like to give them oral antivirals. And the important point is to discuss with the patient prior to the surgery the possible risk of recurrence of herpetic. Otherwise, they often tend to attribute it to the surgical procedure, the cataract surgery that you have performed. And also, it's important in these eyes to do a specular microscopy to look at the endothelial cell count because of prior viral uveitis or keratoconjunctival uveitis. Sometimes you can have reduced endothelial cell count. So if you have that information preoperatively, you can take precautions and ensure that you don't have a adverse outcome postoperatively.
Okay, Sandeep, I think I am hearing Dr. Sandeep.
Yeah, I just wanted to quickly mention that I've seen a few cases where the patient underwent uneventful phacoemulsification and then developed corneal edema. And the surgeon thought it might be some sort of TAS or some non-infective inflammatory disease and started increasing the steroids. And surprisingly, these patients, when you put them on antiviral, the edema disappears, you decrease the steroids. So there can be herpetic infection in patients who have very uneventful phacoemulsification, corneal edema, and then you check the corneal sensation and do the intraocular IOP check. It's very important that the herpetic disease should be kept in mind in these patients.
I have the unusual presentation, you mean?
I have comments, patients who developed corneal edema after
this is more common with
versus herpetic. Usually herpetics usually centralize in disciform after cataract. But for TAS, it is limbus to limbus, and it is immediately post-operatively in the first post-operative days, usually in the first day. And the treatment for corneal edema of herpetic keratitis with corneal edema without any epithelial problems is usually this treatment is steroids. Sometimes we cover it with antiviral topically. But there are two different entities that can be clinically differentiated by history, time of episode, as well as how corneal edema looks like.
So what happens is the corneal edema is there, and then there is an epithelial bullae which ruptures. So actually, if you look, this epithelial defect stains, if you have rose Bengal stain, if you do it, it picks up very nicely the dendritic pattern. So what I'm trying to say is that there can be some masquerading features. So I'm not saying that they always look the same. And I have a few cases where you put them on Valtrax and they respond very well.
Yeah, that condition, what we have seen is more common with CMV, recurrence of cytomegalovirus, endotheliitis, which sometimes can occur in the post-cataract surgery and can present like the patient has a clear cornea for about a week, and then suddenly the patient presents with a diffuse edema or a sectoral edema or coin-shaped lesions, which are very typical of recurrence of cytomegalovirus endotheliitis. And it's more common in the Asian population, especially Japanese population. So this is again something that needs to be looked at. So in those cases, they usually send a aqueous sample for PCR analysis and then provide specific therapy.
Okay, thank you for all. Away from this one about the treatment and precautions and prophylaxis, what is the tips that you need to do when you are performing the surgery? I mean, we are at the end, we want to do a surgery and we are having an opacity and it will may obscure your vision to the cataract. So if someone can summarize, I need this from Dr. Muhammad Husni to summarize this in a few seconds about the tips that we can learn it and we can teach it to others to overcome this opacity in the center of the cornea after the, I mean, there is a scar due to herpes simplex.
Okay, so just to summarize what has been said earlier, that the whole panel recommends the use of systemic antiviral therapy 5 times a day, up to from 3 to 6 months post-op, if you're doing a corneal graft, but this is not as important when you're doing phacosurgery. This is what I recall from all the experts' opinion. And I think the main thing is the post-operative steroids. Exactly like Dr. Gday said, use NSAIDs instead of dexamethasone. I think in these patients, we should push non-steroidals much more than we use post-operative steroids in our normal phaco patients. When you end up with an opacity like this one, if you're doing a cataract surgery, this is usually an easy decision to make. If it is a dense opacity, then I think you should treat the patient with a triple procedure. If of course, when I say a triple procedure, I mean a DALC in these patients, not a full thickness PK. I'm still doing PKs. I'm doing PKs in a lot of patients, not like Dr. Mitra said. We do have a lot of complex patients with complex pathologies, total corneal opacifications with total corneal fibrosis from the surface till the endothelium. So in these patients, we do a triple procedure. I'm a diehard fem to second laser fan, so I do a lot of top hats and mushroom keratoplasties in these patients. And whether to do the cataract in the same setting or not, doing a triple procedure is usually nice for recording, but in my experience, I preserve it only for mature cataracts because clearly it has been shown in many studies, but it's very, very obvious to me that the rate of bouts of trial of rejection, allograft rejection in the patients that we do triple procedure in is much more frequent than in the patient when you do just a PK and then wait for the cataract surgery later on. Compartmentalization of the eye, I think, is important to decrease the severity and the frequency of allograft rejection episodes.
Thank you, Dr. Muhammad. If you can have Dr. Osama. Dr. Osama, which topic now we can go through?
I think Dr. Fogler had a video about the cornea graft with cataract, if he can share it with us.
Cornea with
the cornea graft with cataract.
Corneal graft. So we can go to the last one, the last topic. This one, corneal graft.
Opacity is no, it's okay. He will present the video anyways.
Okay, so Fogla, you are going to present a case about corneal. Which one? Graft or opacity?
He was going to present DALC, I think, Dr. Fogla, he said.
Okay. So how to treat the patient? He's having something? Okay. Okay, let's go. Dr. So Fogla, yeah.
I'll
so
share my screen if you can discontinue.
I will stop my share. Yeah. Go ahead.
Okay. Just while waiting, one more point about
Doctor. Yeah, yes, go ahead, Doctor.
The type of viscoelastic material and the use of BSS plus during the procedure. Do anyone consider that, you know, in these herpetic eye disease patients, like with cornea? So like a dispersive viscoelastic versus cohesive, and regular BSS versus BSS plus.
Yeah, any comments?
Yeah.
I don't have any experience in this.
Dr. Mazen, if you have any answer to Dr. Kodeh questions?
Yeah, I tend to choose those like the dispersive and the BSS plus just because of the weak endothelial cells.
It will be treated the same like someone had the Gotata really and Fuchs.
Yeah.
So it's the same principle, and we're going to discuss that I think at one slide.
Yeah, but I think this is a different pathology. To assume that everyone that had a herpetic corneal disease has a weak endothelium, I think it's an overkill. If you definitely know that this patient has a weak endothelium, if he had recurrent corneal edema episodes and you had to treat it with like hypertonic saline or something, I think definitely I would use an Arshinov soft shell technique and definitely use viscoat in these patients as a viscodispersive OVD. But in all patients that have like a surface keratitis from herpes simplex and ends up with an opacity, surface opacity or a shallow opacity, I don't think I will be using. I will be overprotective for the corneal endothelium. Just a quick question for you, Dr. Gday, before you run away.
Yes.
Do you use, and this is specifically for you because you're a glaucoma specialist, because we have been taught that one of the very major mechanisms of corneal clarity is the role of carbonic anhydrase enzyme. And again, when carbonic anhydrase inhibitors, topical carbonic anhydrase inhibitors were introduced in the market years and years and years ago, we started off not using them in patients that do have endothelial compromise. So in recent times, I've seen a lot of cornea specialists using anti-glaucoma measures post-operatively for cornea grafts, for example, when you use a lot of steroids. So the first line of choice would be Cosopt, Azarga, or whatever that has a carbonic anhydrase inhibitor, which we were classically taught that this is exactly what not to do. So I wanted to hear your take specifically on this.
Yeah, on the carbonic anhydrase inhibitor, yes, I agree. I think they have a negative effect on the endothelial diseased corneas, not so on the like people with stromal or epithelial disease.
Something that is not even discussed at all in the cornea circles and arenas. So that's I just wanted to know your opinion as a glaucoma specialist on
yeah, to be honest with you, I don't have a study or something that to share with you to tell you the exact thing, but I do try to avoid it in my, let's say if I were Fuchs patients or, those who had endothelial damage for other reasons, I do avoid using carbonic anhydrase inhibitors for that reason. And I agree with you, it's not very well discussed, and every time I bring it up, it seems like there's many people don't even know that. Yeah. But,
okay, now may I have a comment, please? Now the same, I'm going to ask a similar question to Dr. Qudayh, which is there any role for the timolol on the endothelial bump? Because we have been taught that whenever we have decompensation, if we use the timolol, not for the purpose of lowering the IOP, but for the maintenance of the and enhancement of the pump of the endothelium. So is there any role for the timolol?
I'm not sure, Dr. Mazen. I don't know that. Yeah.
Anyone is having any answer or idea about
this trend came because in older days, when you had like an eventful and a very stormy cataract surgery and you have a very stormy post-operative course, you get straight keratopathy. And in these patients, usually they have spikes in IOP. And at the time, we were taught exactly the same. If you have an SK, straight keratopathy, next day post your extra cap or the phaco, then start using hypertonic saline and timolol. And I think at the time it was thought that the increase in the intraocular pressure does compromise the endothelial cell function in a way. But in patients that do have like inherent or native corneal edema, like the patients who suffer from Fuchs endothelial keratitis, endotheliopathy, then I don't think there is a role for lowering the intraocular pressure in these patients. I think so. This is my opinion.
Okay, if we don't want to delay Dr. Fogler now, we can go ahead with Dr. Fogler about his
So
case?
this is basically a 83-year-old male, one-eyed, and his preoperative vision was counting fingers, and axial length of 20 millimeters, and IOL power of 30 diopters. You can see there's hardly a visualization of the anterior chamber. So the options were either to do a combined triple procedure or do the keratoplasty first, followed by a subsequent cataract surgery. Or the third option where we could do a partial cornea transplant with cataract surgery.
Okay,
So
Dr.
here
Fogla,
you-
if you can, just 1 minute. Let us see
Yes.
what is our here panelist who's going to take this one or this one. Let us see. Then you can see what you have done. Dr. Ali, if this is your case, what are you going to do?
We face this frequently because of, this is obviously trachomatous scarring.
Correct.
And older generations that we have here in the kingdom, almost many patients, they face with this. It depends on the degree of corneal opacification, if he has a combined corneal edema, and so on. And sometimes we don't make even decision unless we dilate the pupil under a slit lamp. And sometimes even the decision, we have the cornea available during surgery, but we'll see if it is possible that we can avoid penetrating keratoplasty during the same procedure, or laminar keratoplasty.
So what you will do?
We do it just at the slit lamp, or sometimes we do it in the OR, and sometimes if it is very distant and obvious, we do it from the beginning. We plan it from the beginning to do triple procedure.
Okay, can we have, okay, there is any other opinion or any other way of thinking of other colleagues here?
I think I would go for option number 3, definitely, a DALC with the phaco. As you remove the main bulk of the opacified stroma, you can see very clearly the anterior chamber from the decimate. And I think I would go for this, I think. But what I would do is I would do a femtodalc.
Okay. Any other opinions? Dr. Sandeep, Dr. Deepak, Dr. Mazen, Usama?
Yes, sir. I would also prefer a lamellar keratoplasty because I think being a one-eyed patient, we would like to avoid any future rejection episodes. So lamellar also is always a better option than doing a full thickness.
Okay.
Yeah.
If there is no other, we can see what Dr. Fogla have done. Yes, please.
Yeah, I think there is some issue with the video playing on my system right now. Let me look at it and get back, or I can just.
Okay, if you can move it one by one, then we can see what you have now. Yeah.
Yeah, so basically, we went ahead and did a. Let me just sort it out on my system, and I'll revert back. Maybe we can have some discussion. It was working till some time back. I don't know. Maybe on Zoom it's not.
Okay.
I'll just sort it out and I'll get back. Maybe we can have some other discussion. Or the other presentation which I wanted to share was, let me just show regarding the Fuchs dystrophy and cataract. So we can have some discussion on that, and we can.
Dr. Fogla, if we have Dr. Muhammad is having something about the penetrating keratoplasty.
So if you had a patient like this, which presents with a lot of guttate changes and you have a cataract, so how do you make a clinical decision regarding doing a combined cornea and cataract or doing a cataract alone? So how do you follow?
I need Dr. Usama or Dr. Dr. Usama.
It depends on how much the corneal edema, how long is it, how much affecting the patient's symptom. So, and if you had, we need to do cell count. Sometimes it's very tricky to get a good number, but that will give you an idea about cell count and bachymetry. So that will tell you how much that cornea can survive this cataract surgery or not. If you feel that the cataract will, the cornea will not survive.
Yeah.
If you feel that
do you have a
survive,
bachymetry cutoff value that you use? Do you use a
Really, but
specific cutoff value for your pachymetry?
I compare, it's very good to compare both eyes because the cornea thickness from person to person can be different. So if it's like more than 100 from the other eye, that's really is a bit dangerous side. But I don't have a cutoff thickness. I'm not sure. Do you have any?
Dr. Fogla, I think Fogla is having a problem with internet.
I think I have a quick comment on
Yes.
these cases. I have been in the tribunal of a PhD thesis that has been conducted in Sussex, in Brighton, supervised by Prof. Leo, and it was on the assessment of the post-operative course of phaco-DMAC, combined phaco-DMAC. And in these cases, it's very, very inviting to do a sort of an endothelial keratoplasty with the phaco from the first go. The problem that we face back home, especially in Egypt, is that the price of this procedure is very, very high compared to phaco alone. And if off the top of my mind, if I have like 100 patients that do have a sort of an endothelial problem, and we do phaco in all of them, of course, respecting the endothelium more and more and injecting viscodispersive OVD in every step. In these patients, if you have 100 patients, I think 50 of them can be home and dry with just a good, decent phaco, especially if in these patients we do a femto phaco, if we're doing only OZL, or I mean, try as much as possible to decrease the power of your longitudinal phaco as much as you can. And you can get away with this. But in the other 50, then they will have a corneal edema, a persistent corneal edema that will entail us to do an endothelial keratoplasty. So you actually, if you start off doing, I know this is not an attractive opinion, because doing a phaco-DMAC or a phaco-DSEC for that matter is very, very sexy. But if you do a decent phaco for these patients, for most of these patients, you will get a very good result in a big chunk of them. And then the patients that do have an endothelial problem, a severe endothelial problem with persistent edema, then go ahead and do your endothelial keratoplasty afterwards. This is my
Dr. Muhammad, if you want to ask you, I mean, exactly what you will do, I mean, your experience, if you have exposed to this patient, and I'm sure you have exposed to this patient many, so what you are doing in this case?
The problem, Dr. Muhammad, we see these patients all the time. Okay. Now, the problem with these specific patients is that in these specific patients, you cannot rely on specular microscopy. There has been numerous studies that tells you that when in the number, how the specular microscope works is that it gets a very small part of the endothelial sign and then multiplies or interpolates the number on the whole side of the back, on the whole back side of the cornea. So what happens is the number that comes out of the specular microscopy in patients that do have considerable Gattata or Fuchs is not reliable. So you rely mainly on your clinical sort of sense. So of course, if you have a very, very thick cornea, if your cornea is like 680, 700, then this is a no-brainer. But when you have a thicker cornea, which is not totally opacified, you can't see the excrescences with your eyes. You know this is a cornea Gattata. The patient had previous episodes of corneal edema that you had to give drying agents for the cornea to dry. I think you could start off with a very, very cautious phaco with and by an experienced phaco surgeon. And in a lot of these patients, I'm not saying that this is the rule, but in a lot of these patients, you can actually get away with this. One of the patients that I did this to was actually a physician who lived in the UK, who was sent to me from his son, who's an ophthalmologist in the UK, but he was not a cornea specialist. And he was sent to me back home. They are from Egyptian origin. And he came to me to do him a phaco-DMAC. And I did him a phaco. I explained everything to him. And we decided together that we're going to start off with a phaco. I did a phaco in one eye and he was absolutely fantastic. I did a phaco in the other eye. He was absolutely fantastic. This was years and years ago. And up to this very moment, he didn't need a DMEC or a DSEC. So I think in these patients, start off with the wise decision of just doing the cataract and see how it plays.
Dr. Ali?
What Dr. Hosni has mentioned is right. I mean, you have to discuss it with patients as well as how much budget he has to, sometimes they cannot afford doing endothelial keratoplasty. But there are obvious things. If he has diffuse corneal edema or obvious central corneal edema, and he has minimum cataract, this is a good indication to do endothelial keratoplasty combined with cataract surgery. The other thing that I don't rely on thickness. Thickness, if it is too much like 700, it is obvious that this patient has corneal edema. But there are patients, normal patients. In my family, for example, we have thick corneas like 600 and we have good endothelial cell count. So it is combined of thickness as well as specular microscopy and other things. My cutoff, which is a hard question, sometimes 900, 1000 is probably the highest, but there have been reports that the grafts or corneas can live with only 400, 600 square meter. And as you know, specular only measures 1 millimeter, so it doesn't measure a lot of things.
Okay, Dr. Mazen, please.
Dr. Muhammad, yes.
To be considered also is to see if, for example, you plan to delay the endothelial cell count, you have to counsel the patient that you will do cataract, but there is high risk that or need that you will do endothelial keratoplasty. And the patient has to understand that you can do it at 2 stages. And sometimes if they have limited budget and you can have good visibility, you can always do cataract and with corrections for the induced hyperopia with the endothelial keratoplasty, and then plan to do endothelial keratoplasty at a later stage.
Okay, Dr. Mazen.
Yeah, I would like to highlight 2 points actually in such patients. The first thing is the IOL calculation, which will lead me then to the second point. In the IOL calculation, we have to consider that there will be like a hyperopic shift after such operations, after the DMEC, for example, or DSEC, there will be hyperopic shift. So it is recommended for the IOL to be overcorrected or to target for about myopia 1 to 1.5 diopters, because when the thickness regresses, then the K reading or the curvature of the eye of the cornea will go down. Now, this will lead me to the other point, which is, as the colleagues mentioned, that it is difficult to get the endothelial cell count in such cases. Now, one of the recommendations is to use glycerol drops, okay, glycerine drops in the clinic to remove the edema from the cornea, of course, after using anesthesia drops, because it's very painful. So what do you think? If we put the glycerine drops in the eye and we wait for about 10 to 15 minutes, the cornea will lose this huge thickness, then we can get better K readings and we can get better endothelial cell count. So I'd like to hear the opinion of my colleagues.
We can ask Fogler because he is the one, he started this one.
Yeah. So basically, this is a flowchart of clinical decision-making that I follow. So basically, you can have a patient with Fuchs dystrophy with corneal guttae. If the patient is asymptomatic, you don't need to do anything. If you have a patient who's visually symptomatic, especially with central corneal guttae, you can have patients who have glare while driving at night. So especially in the West, in the US, they are found with people with large pupil diameter and large mesopic pupil. They often are symptomatic even when the crystalline lens is clear. So in those cases, if the guttae are located to the central 4 to 5 millimeter area, you can consider doing the Decimet stripping only, where you just remove a central area of the Decimet membrane over a 4 millimeter or 5 millimeter zone. and wait for the cornea to clear spontaneously over the next 3 months, or the process can be accelerated with the use of rho kinase inhibitor drops. If it doesn't work, then obviously you have to fall back on doing a DMAC surgery. Sometimes the guttae are beyond the 5 millimeter zone. In such cases, if the lens is clear, you basically have to see if the anterior chamber depth is adequate, because for a subsequent cataract surgery, you need to have enough working space so that you don't damage the endothelial cells of the graft. So in that situation, you can just do a DMAC procedure alone or an endothelial keratoplasty without sacrificing the crystalline lens. But if there is a cataract in place, then I think you have to make a decision based on the existing endothelial cell count and the pachymetry values. So there is one study published where they have used 650 microns as a cutoff value, and they have done cataract surgery in those patients, and they found that if the pachymetry value is more than 650 microns, almost 24% of the patients require a subsequent corneal surgery. So they try to recommend that if it is more than 650 microns, maybe think about doing a combined surgery. So again, if you have a patient where the cell counts are adequate, always look at the anterior chamber depth and whether the pupil is well dilating or whether the density of the cataract as well, before considering doing only a endothelial keratoplasty alone. And always consider a hydrophobic IOL if you are going to do a cataract surgery, because hydrophilic IOL can opacify with subsequent endothelial keratoplasty surgery. Now, the thing is whether to use premium IOLs in this coexisting disease. Well, if I'm doing a combined surgery, I don't like to use a multifocal lens. And even a toric lens sometimes can be a bit challenging, because when you manipulate the donor lenticule to move it into position, you tap the cornea, there is a possibility that your toric lens within the bag can sometimes rotate from its desired position. So for me, I think I usually, when I'm doing a combined procedure, I like to use a monofocal lens. But there is a study by Frank Price where they have shown that if you do a DMAC procedure beforehand and then plan a subsequent cataract surgery at a later date, you can then go in for premium lenses, because at that point of time, you don't have the refractive surprise and you can choose whatever lens you want, a toric lens or a multifocal, and you can achieve good results. So I think this is the flowchart that I use, and this is quite reasonable. Would be happy to have comments from the other panelists on this.
But we go back to the question of Dr. Mazen.
Yeah. Using the glycerine drops in the clinic when measuring the K readings and endothelial cell count. What's your opinion, Dr. Fogler?
No, if the cornea is already edematous so much that you have to use glycerine, then I'm not worried about the endothelial cell count, because I know that the whatever endothelium is there, it's not functional. It is making the cornea very edematous. In terms of looking at the K values, yes, sometimes if the cornea is very edematous, you cannot achieve a adequate keratometry value. So in that situation, to obtain ideal K values, maybe you can deturgest the cornea by using glycerin, the epithelial edema can subside, and then you can take measurements. Often you can take measurements from the fellow eye as well, because the K values among two eyes are quite usually identical. So that can be used for your IOL power calculation as well.
Go to Dr. Mazen comment about this should be differentiated about DMAC and DSEC. So the more hyperopic shift with the DSEC, but DMAC is less likely to cause hyperopic shift.
It still causes a hyperopic shift of about 0.5 to 0.75, but less.
Yeah. Yes. It's less amount. That's what I mean. It's slightly different in the amount.
Yes.
For cataract, if we want to do the cataract surgery itself, for someone who don't have to count the endothelial cells or this one, and he found there is an edema that's not much, and he can see. So in one way or another, we can do the surgery if the patient is passed and succeed, as Dr. Muhammad Husni mentioned. So then well and good. If not, then he have some problem in the cornea. We can
usually one of the indirect ways of assessing the health of the endothelium is if you ask your patient specific question that when you get up in the morning, how is your vision? Is it blurred? Do you see halos around light in the morning when you get up and it gets better by the afternoon? Then you know that this endothelium is unlikely to survive. So then that's an indication where you need to have a combined surgery. If the patient does not have this early morning blurring of vision, then you can safely consider doing a cataract surgery alone without doing a corneal procedure. And also in Fuchs dystrophy patients, because of the guttate changes, the Descemet's membrane is also thicker. And often these patients can have, a detachment of the Descemet's membrane in the post-operative period following cataract surgery, even with atraumatic surgery. So this is also something that you need to watch out for, because the adhesion between the Descemet's and the cornea is quite loose. So it can very easily detach. So you may need to watch out in the post-operative period and do air injection for rebubbling to kind of put the Descemet's back into position.
Okay, I think it's fair enough about this one. We can move to another.
I can show that video on the corneal opacity and cataract. It's working
okay,
now.
it's ready.
So,
if it is ready, yeah. Okay,
yes,
let's.
Yes. So you can see that what we did was we used a Hesburgh-Barron trefine to do a partial thickness corneal trephination. And then we debulked the cornea about 70 to 75%. And it's important when you're debulking not to stretch the cornea too much, because otherwise you get the whitening effect from the stretching. Then we put some dispersive viscoelastic like HPMC, hydroxypropyl methyl cellulose, on the cornea. And you can see that the visualization is much better than what we started off. Now, this elderly gentleman had a non-dilating pupil, so we had to use iris hooks to improve the working space. So we place, you can use Malyugin ring, and then we stained the anterior capsule with trypan blue, because the visualization, although it was better, but it was not perfect. He had a dense cataract, so there was hardly any red glow. So using trypan blue, we were able to complete our capsular axis. And then we, did the hydrodissection and managed to complete the phacoemulsification procedure. Since it was a dense cataract, we took our time to not to hurry up, and we made deep trench, and we had to repeatedly apply the HPMC on the surface to keep the visualization clear. At the end of surgery, we were able to, let me just speed it up. You can see that we placed the lens inside the capsular bag, the Rayner lens that we used. And once it is in the bag, we remove the iris hooks, we washed out all the viscoelastic, closed the main incision. Then we went back to the cornea and we created a further deeper plane of dissection, which is at about maybe 90% depth. And we made this groove in the periphery using a pair of blunt tipped fine scissors. Now I use the specific instrument that I've designed, which is available from stores. It's called the stromal pocket forceps. And then using a kind of modified peeling technique, the left hand is doing most of the work. There is a tooth forceps that's trying to peel the stroma off, and the right hand, the crescent, is just breaking the fibers as they are separating. So this helps maintain a single plane of dissection. And once you have completed with that, you can then bring in your donor graft, secure it in position with sutures, and that's pretty much the end of surgery. This is how it looked in the early post-operative period. He had uncorrected vision of about 618, improving to 612 with pinhole. And at 2 years, you can see that the vision is maintained, and with correction of -1 with -1.5, he was able to see 6.9 plus. So this was the advantage, was that this was an eye with a short axial length, only eye. Doing a triple procedure sometimes carries the risk because it's a short eye, and even if you try to do it under local anesthesia, there can be a upthrust. The risk of expulsive can also be there. Whereas here, doing a DALC with a phaco IOL, we were able to keep the chamber, perform the surgery in a closed chamber. There's another case with corneal opacity where we did a DALC with a phaco IOL, and you can see that the outcome is pretty good. So the advantage is that you maintain the patient's own endothelium, no risk of rejection, and you don't need to use steroids for a pretty long period of time. The only disadvantage is that the IOL power calculation is not as accurate as doing sequential surgery. If you do a DALC first and wait for suture removal, and then you calculate the power of the IOL and do the cataract surgery, you can achieve much better refractive outcomes. Here, the error is usually plus minus 2 diopters, and I usually choose to aim for more myopia so that even if the patient has a little bit of myopic error left, at least he'll have a good reading power, rather than try to be emmetropic and end up with a hyperopic outcome. Then he needs glasses both for distance as well as for reading.
What
Maybe
care,
also-
Excellent.
what care readings do you use, Dr. Fogler?
I use a K reading of 43 diopters, and this is something that you can evaluate your own cases that you perform and see what kind of average K reading that you are achieving. So for my usual dull cases, if I see the average K reading is somewhere in the range of about 43, 44. So I use that for my dull as well.
I usually use 44, 45, but I am the
Yeah.
same with you with myopia.
Yes.
I think Dr. Muhammad, you want to share something regarding this one? Sorry?
Are we presenting any other cases? I mean,
Yeah, there will be, but we are now in a corneal trend. You have something about that, Dr. Ali? You can share with us your video.
I
if you
have 3 different or 4 different cases. One is extremely thin cornea with Ehlers dullness. I don't know which one is interested to you.
No,
And
about this topic exactly. You have something related to the, DMAC, basic, or penetrating keratoplasty, or something like that?
No, cataract and different corneal disease.
Okay. Okay, Dr. Muhammad, I think you have anything about this one. You tell me about penetrating keratoplasty or DMAC, this one?
Actually, yes. You can hear me, right?
Yes, we are hearing you.
Actually, yes. I have like a straightforward video.
Okay, you can share with us your experience with this one.
The thing is to maximize the benefit. I just wanted to present a common scenario that we all sort of see, and just to generate a discussion and to, to benefit from the wisdom of all the renowned corneal surgeons that we have. We all do transplants. Some of us do penetrating keratoplasty, as myself. I still do. I have very good results with the femtosecond penetrating keratoplasty. But in these patients, when you have a penetrating keratoplasty, you can get bouts of rejection or, a trial of the immune system just to react with the graft. We control this in most of our cases. But with the steroids that we use and topical steroids, systemic steroids, and with the inflammation that's going on, sometimes you end up with a pretty nasty cataracts. And you have it like after 1 year, after a year and a half. So my question to the panel, if you do have a cataract after you did a graft, when would you be inclined to operate? Is it like after 6 months of doing the corneal transplant, or after 1 year, a year and a half, after removing the sutures? What would you do?
Okay, Sandeep.
It will depend upon the cataract. If it's very mature, probably we could go early, but normally we should wait for the sutures to come out, the astigmatism to settle down, and then approach the cataract surgery, because at the end of the day, you want to have a good refractive outcome. I mean, whatever lens you're going to implant. But the scenario will change if you have a very mature cataract. I mean, you cannot keep waiting in these patients. So yes, ideal situation will be.
Will it change, Dr. Mitra? I mean, if you have a mature cataract, 3 months out of the PK, would you do a cataract that early, or would you hold the horses?
I think it's better to hold. Just remove the stitches, get the cornea stabilized, and then wait another couple of months, and then go ahead and calculate your IOL power and do the cataract surgery.
I mean, it is
if you have
different
not done
between
a
one
combined.
patient from another one, or you are depending on, there is a time you have 6 months, 8 months, or it can be vary from one patient to another.
Yeah, it can vary, but the question is, the question what Dr. Mohammed asked is, if you have a penetrating keratoplasty, that's what you're asking, penetrating keratoplasty, not a dull. With dull, the scenario will be different. So for penetrating keratoplasty, I would wait for the sutures to come out, the astigmatism to settle down, and then go and do a phacoemulsification and then proceed.
And this is usually in the neighborhood of a year, right?
Yeah, yes.
So this is exactly that.
Yeah, but it also depends on what is the status of the fellow eye and what is the vision in the eye with the keratoplasty. If let's say there is a dense posterior subcapsular cataract and the patient does not have useful vision, then sometimes the patient wants some amount of visual recovery. So you have to take into account the risk of the viability of the graft versus improving the vision as well. And if you have a total cataract, sometimes you need to look at whether the cataract is going to become intumescent with shallow anterior chamber which will again make the cataract surgery a little bit more difficulty. But yes, there are many factors that you need to take into account, because in the presence of suture, whenever you do a cataract surgery, we all know from our experience doing corneal transplants, is that once the sutures are removed, you can have significant shift in your astigmatism as well.
So yeah, so this was one of the questions that I was going to ask. If you have a patient coming from a faraway place, would you insist that he does the suture removal first? And even if the patient has done the surgery, let's say a year ago, would you insist that he remove the sutures first and then come back later, let's say after a month, to do a proper biometry? Or would you go ahead and
no, if ideally, yes, if the cataract can wait, and if the other eye vision is good, we can do a suture removal, wait for a few weeks for stabilization of the surface. If not, then I would remove the sutures, see the patient the following day, and try to assess what kind of values my cornea looks like. If the cornea looks not much of astigmatism, maybe I'll try and use some of those keratometry values for IOL power calculation. And let's say patient has significant amount of astigmatism, then I would try to use an average K. I will do my cataract surgery. I will not aim for a toric IOL, but at the end of surgery, I will try to replace sutures in the cornea to try and minimize that astigmatism using an intraoperative keratometer.
You see, I agree. But the thing is, a lot of our patients, and I mean a lot of our patients, especially in the in the government hospital and the university hospital I work in, they come from very far away places, and to accommodate them for one day after removing the suture, I think is pretty much of a hassle. So you actually answered one of my questions that I was going to ask, is that would you go for a toric IOL or not if there is a very obvious topographic astigmatism? Or would you go in these patients for like a femtosecond LRI or an arcuate incision? So this is something that I wanted to ask you about, Dr. Fogler.
No, ideally, if you have a patient who can wait, then you do a suture removal and you plan for a toric IOL, which can give you the best outcome. But if you have had to do a cataract surgery and then later on you do a suture removal and the patient has residual astigmatism, then I go and do a femto AK and followed by a topography guided surface ablation to try and address the astigmatism. Like the femto AK can give you a gross correction, and after that you wait for a couple of months, and then if you still have some residual refractive error and your patient desires further correction, we can go ahead and do a topo guided PRK to address that.
Yeah, we actually did a PhD thesis on this specific matter, and we combined both modalities, but it was only 1 month difference between the astigmatic keratotomy and the contour or the topography guide. And we had very, very good results actually in these patients.
Yeah, so even I do that. Sometimes if I have an astigmatism of 11 diopters, which obviously you cannot correct using the surface ablation. So we do a femto AK using a 7 millimeter or 6.5 millimeter optical zone. And then from 11, it drops down to about 3.5 or 4, something like that. And then we wait for the final effect at about a month or 2. And then once you have a stable topography, then you can go ahead and do a contura and you can achieve much better outcome.
Okay, so you answered the question. You're not a big fan of toric IOLs in these patients.
No, we do customize toric IOLs as well. But if your patient, already has an IOL in the eye, and now you can't do, then you have to go and do a piggyback lens or something like that. But if you want to keep the procedure extraocular, then maybe a femto AK and a surface ablation is much better rather than going into the eye, which carries a risk of, losing more endothelial cells. So that's again an option.
Have you found that in these patients, sometimes marking the cornea and getting the IOL, the toric IOL on axis is a little bit tricky than in normal, like virgin cataract cases?
No, sometimes getting the axis itself is very difficult in these eyes, because if you measure them on 3 different instruments, you don't get exactly the same axis in all 3.
Okay. Okay. Yeah.
So there can be a few degrees. So this is where it depends on which optical zone you are using to calculate the astigmatism, the astigmatic axis.
My question was much more simpler and crude. If you know the axis, all instruments agree on the axis. I found it a bit tricky to mark the axis and put it bang on the axis in toric IOLs in these specific patients. Have you ever suffered
Why
from
is that, brother? But why is that, Dr. Muhammad?
surgeon?
Dr. Muhammad Hosni, why you feel it's difficult to mark the axis here?
Sometimes marking the cornea with all what's going on around the limbus is a little bit tricky.
No, sometimes you have difficulty because the graft and the pupil is not exactly in the center; it's slightly nasal, and then you have the graft. So you're not able to correlate the normal anatomy because you get confused between the limbus and the graft-hose junction because you try to look at the graft-hose junction as a So that is where sometimes you can have issues in trying to identify.
Okay. Thank you, Dr. Muhammad. Thank you, Dr. Fogla. We want Dr. Ali to share with us some of his videos so we can have, you select whatever you think is interesting, then we can go and discuss.
Let me find the file that I need to share.
While waiting, I'll ask Dr. Fogla. You had mentioned earlier that the type of lens, whether hydrophobic or hydrophilic in these cases, I think you said you would rather do hydrophobic.
Yes.
But isn't the Reiner hydrophilic?
Yes,
that was a DALC with phaco IOL. So in that situation, we are not putting any gas bubble inside the eye. So usually when you're doing an endothelial keratoplasty, you use air, or specifically if you're using non-expansile mixture of sulfur hexafluoride, then because of that you can find that there is opacification of the hydrophilic IOL within the pupillary area. So if we get sometimes cases of pseudophakic bullous keratopathy where you have to do a endothelial keratoplasty and you're not aware of what IOL the previous surgeon has placed inside the eye. So what we do is we avoid using long-acting gases like sulfur hexafluoride. We use only air, and we also try to use a miotic at the end of surgery to constrict the pupil so that the contact between the gas or the air and the IOL is minimized, so that you don't get opacification of the lens.
Actually, and there were other reports that said that hydrophilic lenses do have a static force between the lens and the endothelium and does cause further endothelial cell damage. I had the same comment in my mind that Dr. Giri said, but I just wanted to be the kinder guy.
So I'm not the kinder guy.
I let it slip.
Dr. Ali, you are ready? Or?
I'm trying to.
Okay.
So we had for that day the lens
till
was
what
30
time we
diopters.
finish?
So we got only that in Reiner. We did not have it in the other one.
No, we are not seeing your screen. Whenever you will see, I will tell you. So meanwhile, can we just have an idea about a patient we are going to do a cataract and he is having pterygium. I think this is we are seeing a lot in many patients, and we want to hear about the experience in dealing with this. To do that, okay. Dr. Ali, okay, you start.
Yeah, this patient is actually a patient who is a known case of Ehlers-Danlos syndrome. As you know, with extremely thin cornea, she lost her eye during childhood. And the remaining eye is this eye with vision of 20/40. Unfortunately, she had multiple trauma even with this eye. And then, as you can see in here, she developed thinning inferiorly and adherent glaucoma, as well as she has fashionable graft, which is half donut shaped with the amniotic membrane, because you cannot suture to the cornea. All sutures were to the limbus. And the remaining cornea here, which is attached, is with fibrin glue and amniotic membrane. She developed cataract and she's a glaucoma, and we have difficulty in IOL calculation, how to approach her, whether to do corneal or scleral. So since she's Ehlers-Danlos syndrome, as you know, both cornea and sclera are thin. So we want to do cataract aspiration since she is probably in her teens, 15 or 16 years of age. So this is her condition. We tried to do scleral, and in spite of this, we had perforation, and the pupil doesn't dilate because of adherent glaucoma. So we managed to do capsulorhexis, and then we completed with a can-opener technique. As you can see, even iris is prolapsing. And it's mainly lens aspiration. So we have to do the lens aspiration after capsulotomy. And this was done basically with Simcoe. Remember, this is only one eye, extremely thin cornea, as well as sclera. And after we have the cataract aspiration, we inserted the IOL, which is one piece IOL, I think 3-piece IOL. And then we tried to do matrix suture to close, and then we supported it with sclera. Fortunately, patient did well, and I have been following this patient for more than 10 years, and she kept the same vision without any problem. So this is one of the approach to do this case.
Okay, you want to ask anyone of the colleagues here for opinion?
No, I mean, this is rarely seen cases because it is
anyone have seen or done some cases like this in the panel? Okay, so we go to the next case.
I have had some of these cases with Ehlers-Danlos with thin cornea and thin sclera. So what we have done is we have done what is called as epikeratoplasty. So in these kind of cases, to reinforce the cornea, you can do a 360-degree conjunctival peritomy. And when you're doing the peritomy, you try to harvest the limbal palisades within the peritomy that you do so that you don't lose out on the limbal stem cell. Then use alcohol to debride the epithelium. And once you have cleared the entire epithelium, you take a large diameter corneoscleral graft. Like you have to fashion it manually, have at least 1.5 millimeter rim of sclera all around. This can be placed on top of the cornea, and then you can try and suture it at the episclera. You can use a combination of sutures and fibrin glue to secure it at the periphery, and then you close the conjunctiva on top. And by doing that, what you do is you achieve like a normal corneal thickness. And then later on, if you have to come back and do a surgery, you don't have to worry about the wound becoming very thin, not being able to suture the wound. And even if the cornea is not clear, even you can do a central small penetrating keratoplasty because now you have a normal central corneal thickness. And these corneas are very prone to injury. Even if they sustain a minor trauma, they can have rupture, and which can be very difficult to repair. If you want, I can share you one clinical photograph that I can show you of the patient, or maybe at the end of the presentation, I can try and show you one clinical case where we have done an epikeratoplasty.
Actually, we did a lot of epikerato patch for patients similar to this one to avoid any trauma. And we used to do it in the 90s. When it was commercially available, they usually come in a frozen state, which is 300 millimeter thickness, and we put it limbus to limbus after we have 360 degrees conjunctiva periotomy, and then we put the conjunctiva over it. And I have other cases which is similar. I mean, that kerato patch, sometimes we have problems with this, not only, not a lot. I mean, one of the cases that I presented in certain meetings, they developed epithelial ingrowth between the kerato patch and the thin cornea to the degree that one of the patients have even fluid level. And I have some cases, one case of this one, and this was reported. Another case, sometimes they have difficulty in having the epithelium healed over the central cornea diameter. But as Dr. Vogler mentioned, this is one of the approaches to strengthen the cornea is to have epikeratoplasty from the limbus. The second patient I'm sharing is a patient who has diffuse corneal.
It is in the same presentation, or you will change? You will stop and.
No, I'll stop this one. Huh?
Okay.
There's one more point before we move on, if I may.
Yes, Dr. Qadeh, please.
I use a similar, like I have similar cohort of patients where I do tubes and so sometimes tubes. Yeah. The biggest thing is that I do worry about the corneal melt and scleral melt, and typically this would be a rheumatoid arthritis patient. So I do make sure that I get the rheumatologist involved and that their rheumatoid factor are within normal and that they're under very good control, because once we get a corneal melt or a scleral melt, it tends to keep keep on, and it's hard to control afterwards if you don't get it from the beginning. I don't know if that would be similar to your case, Dr. Rajfi.
Well, I haven't seen the pictures, but I mean, it could be.
No, I meant the thin cornea case that you just showed us.
I mean, Dr. Qadeh, you mean there will be a problem of corneal melting in this case?
No, I mean, usually the cornea doesn't melt in these cases, but they are prone for any minor trauma that will rupture. And these two siblings, there are two siblings. This patient in particular, she lost her eye completely in the other eye. And her sister also, she has only one eye. So they have multiple trauma with a piece of finger. They can rupture, and they are very difficult to have their corneal laceration repaired because they have extremely, with cheese wiring and everything. So it's always better to avoid it and to have a protective corneal tissue, as Dr. Vogler mentioned.
One
Can
comment,
we move
I
to
think
that
is,
second one here?
One comment, it's very important when you do cataract, always examine the cornea all around if there's a scar and thinning area. So always try to do the incision, avoid that area. So sometimes we will go to the cataract surgery straight without documented if there's any area of thinning. So always if there's any area of thinning, always try to avoid it when you do the cataract surgery.
Sure.
Okay, Dr. Ali, can we see the second case?
This patient is interesting. He had ECC in the other eye successfully. And this patient he presented, he had obtained his vision when it was clear as 2040 with this cornea. The question whether to do just cataract surgery or penetrating keratoplasty.
This is a question to have an opinion, or you will show the video a little bit?
Yes,
oh.
Because this is a famous patient of ours, but we did this case and it has some consequences.
Okay, in this way, Dr. Mazen, where is Dr. Mazen? Dr. Mazen, you are with us?
No, the question whether to do just cataract surgery or to do.
I think it depends visibility in the microscope. Sometimes the microscope is very tricky to see. So it depends on what you can see.
Okay, I think Dr. Qadeh will be busy, so we'll miss you in the remnant part or the balance time that we are going to continue. But I will try to contact you after I finish this webinar. I think it's a daytime video, right, Dr. Uday?
Thank you very much. It was a pleasure, and I apologize. I have to leave for a teaching.
No, thank you very much for your time, and we are a pleasure that you and honor to be with us. Thank you very much for your share.
Thank you.
For the second time, shall we proceed?
Yes, please, Dr. Ali.
This patient has also a predisposed condition for disseminate detachment that we have described. We call it a blue dot degeneration, present on both eyes. So with this in mind, we elected to do just phacoemulsification with this. And first of all, we did vision blue, and this is important to visualize the anterior capsule. And you will see that with vision blue and putting viscoelastic substance to get the pupil dilated. And you will notice that even capsulorhexis will be much clearer after we do the capsulorhexis started. This was done successfully also. You notice that the pupil is also not so dilated. And the peripheral of the cornea is more dense than the central one. And in these cases, it's always important to do manipulation of the lens and nucleus, rocking it around, and sometimes doing more or less anterior phaco. Phaco was started with having the central groove, and then it was completed with a chopping technique. And you will notice that as soon as you do more of the phacoemulsification, the visualization is much better, and the red reflex will appear much clearer.
Dr. Ali, is there any precaution you have to take in this case?
Sometimes it's important to get the pupil dilated, and even side illumination is helpful. Sometimes using the intraocular illumination on sideways to enhance the capsulorhexis. And sometimes with the, for example, in Lumira 700 Zeiss microscope, you can reduce the light and have better red reflex with this, with the hazy cornea. You can see red reflex is obvious now.
But I mean, this patient, they will get improved vision nicely, even though there is this
yeah,
opacity.
I'll let you know, because he has very strange story. We did surgery successfully without any complication. Postoperatively, his vision did not improve because he developed disseminate detachment. As I mentioned before, he has an entity, we described it as, you can see even some of the cortical material or nucleus material is left because of peripheral corneal haze. And this sometimes cannot be avoided because of poor visualization. And with this disseminate detachment that he developed, we stayed for months, and we decided to observe him because there isn't any cut with the OCT. And he waited for months, and then he consulted some of our colleagues, including Dr. Aliou. And he was booked for penetrating keratoplasty. He stayed probably for 6 months. And then after that, his disseminate detachment spontaneously attached. And then after attachment, his cataract, his vision improved to 20/40 again. So this can happen sometimes with these cases without the need for corneal transplantation.
Thank you very much, Dr. Ali. It's very interesting cases. If there is any question to Dr. Ali, Dr. Fogla, or Osama, Dr. Muhammad, Dr. Mazen? Any comments? If you allow Dr. Ali, if we can go to another topics, we want to actually to tackle some certain topics that's very important for all ophthalmologists. When they are doing a cataract surgery in a patient, they are having a pterygium, how we can deal with, and we can have your opinion on. Dr. Ali, we can start with you. If you have a patient with pterygium, small pterygium, or if it is large pterygium, it's crossing the center. How do you deal with this patient? Do you have a problem with IOL calculations? Do you remove first and wait after? All these questions we need to just highlight it, and we will have different opinions.
You know, with pterygium, it depends on how big is the pterygium. For example,
can you stop sharing so I can share the screen with some photos? Okay, go ahead.
I think I stopped sharing, right?
Yeah, yes, yeah. Okay, continue, Dr. Ali. Yes, we are hearing you.
For pterygium, sometimes depends. If it is a small, I mean 1-2 millimeter, and doesn't affect the vision, and I do topography and there is no change, I usually leave it and do just the cataract surgery. If it is causing astigmatism or some, I mean, cosmetically is not acceptable, like the case that you are showing here.
We are having two now. It's very small one, just in the periphery, in the top one, and there is another one here.
This is obviously need to be removed during the cataract surgery. And the K readings, I usually use this and ignore the case here. And I remove the pterygium and I proceed with the cataract surgery.
Okay, Dr. Fogla, please.
Yeah, I agree in the sense that if the pterygium is inducing significant amount of astigmatism, it's always better to address the pterygium first, because if you find that there is about 3 or 4 diopters of astigmatism, then you have to decide whether you're going to use a specific toric lens or you want to go with a regular monofocal lens. And often you find that if you remove the pterygium, this astigmatism comes down. The against the rule astigmatism is induced by the pterygium encroaching onto the cornea. Patients often want improved vision. At the same time, they want improved cosmesis as well. So what we do is, by doing a separate pterygium surgery first with a nice conjunctival autograft, you can ensure that they get a normal looking eye before you can proceed and do a cataract surgery.
So you will separate. You will start with pterygium, then wait after.
I have
right?
Yes, I'll do a pterygium surgery first and then followed by a cataract surgery.
For how long you will wait? For how long you will wait?
You can wait for a month. I think that's more than enough. Till the surface is kind of smooth and you find on astigmatism that there is no significance. So you don't need to really wait for a long period of time, because there are no sutures in the cornea, no cuts in the cornea as such. You just wait for the surface to become smooth and stabilize. Yeah.
Suppose, Dr. Fogla, if we have a patient, he is a myopic patient wearing a glass, and he's having astigmatism, and he's having a pterygium and then a cataract. So in this way, how do you know which one is related to the pterygium itself, or is related to the previous, astigmatism is not related to the pterygium itself?
No. In the sense that the myopia is a different problem. In the sense, the pterygium, we know that it induces astigmatism. It makes the horizontal axis steeper compared to the vertical axis. So if you see a typical pattern, you know that's so. You will find that just ahead of the pterygium there will be flattening where the head of the pterygium is, and the rest beyond that you will find the steepening. So it's a typical pattern that you see. So I don't think you can separate the the astigmatism between pterygium and the lens-induced astigmatism just by looking at it.
Okay. Any comment, Dr. Muhammad?
Yeah, just a small comment that Dr. Rajesh Fogla has a very, very, very good video on conjunctival autografting in pterygium. I think he posted this on YouTube like 10 years ago or more. And
Maybe you don't remember now. You don't remember.
since it has been, well, honestly, it has been one of the prerequisites in the training of our residents to watch this video. So thank you, sir. You have contributed to residents in Cairo University.
Thank you, Doctor. Okay. So we will have to move to also, if there is any other comment regarding this pterygium, Dr. Ali or Dr. Osama, and Dr. Mazen, Sandeep, any other comment than what already mentioned?
Actually, personally, I will wait. I'll do the pterygium whenever it is progressive, whenever it is like the one on the bottom of the screen. If it is very small, no, I will go for the cataract. But otherwise, I will remove the pterygium first, and I will wait for 1 month if the cataract is significant. So no need to wait more than 1 month. But if the cataract is tolerable, then I would wait for 3 months, actually, because this will give the cornea a better stabilization for the K readings and the astigmatism.
Okay, Dr. Mazen, this question for you. If you are having a small pterygium, but yeah, not that much, not big as in the photo down, not smaller as here, but a little bit in between, and he is doing there is an astigmatism about 1.5 diameter, something like that. And you want to do, I mean, or 1 diameter, let's say, between 1.5, and there is a cataract. So you will remove, or you will correct the astigmatism by doing some, for example, toric, or you will do, what is your plan?
If the patient is asking for cosmetic removal, then I have to remove the pterygium. But usually I remove the pterygium first. I don't do both in the same session. The other indication to remove the pterygium is if it is progressive. All right. Otherwise, I will leave it.
Okay. What you will do for the astigmatism, if there is an astigmatism?
If it is small, let's say if the astigmatism is only 1 diopter, it means that it is a very small pterygium. Otherwise, the astigmatism should be high. So since it is small, I'm going to deal with it as corneal astigmatism, and maybe I will implant a toric IOL. But the pterygium should be stable. If it is progressive, even if it is small, of course, I cannot put toric IOL because the astigmatism will change later while it's progressive. Yeah. So many factors will affect the decision.
Okay. I think we want to go actually to keratoconus to talk about keratoconus and cataract surgery. I will start a little bit with Dr. Sandeep and Usama. Sandeep, you are with us?
Yeah.
Okay. So if you have a patient, is having a keratoconus and maybe already treated or whatever, there is different types of treatment. I mean, if you do, for example, rains and he's having a cataract, what you will do?
So the first thing is the keratoconus, whether it is a stable keratoconus or it is a progressive. If it is a progressive keratoconus, that means you have topography over a period of time, then I think the first thing should be that to stabilize the cornea with cross-linkage, and the next thing will be to stabilize the cone with a ring, or if you have enough corneal tissue, you can even go ahead and do a PRK topo-guided to correct the ring, correct the cone. Now these things are basically to aim at regularizing the cornea. So once your cornea is regular, then your approach will be to correct the lenticular opacity. At whatever age the patient comes, I mean, the first most important thing is to stop the progression of cornea. So if it is an old patient, more than 40, and his cornea is stable, then the approach should be to regularize the corneal surface first. Either you can use, again, the topo-guided PRK if you have enough corneal thickness, or you put a ring, and then you can approach a cataract surgery and put a toric IOL. But to approach with toric IOL in irregular cornea, it's absolutely not going to help because the vision is not going to improve. So the cone has to come to the visual axis for the patients to see better. So that's my approach for keratoconus patients.
Okay, Dr.
If the
Mazen.
keratoconus,
Sorry, yeah.
yes, yeah. If the keratoconus is very advanced, in that case, of course, a DALC will be the first thing to do, and then wait for the cornea to stabilize, and then in the second stage do a cataract surgery. Combined cataract with corneal transplant, I think I do very rarely in these cases.
Dr. Mazen, in case of keratoconus, also how do you can decide about the K readings?
Okay, great. Now I agree with Dr. Sandeep. There are several factors affecting the decision. Stable or unstable, of course, age of the patient. The cornea is clear or there is an opacification, a scar because of keratoconus. And the third factor, whether it is keratoconus or pellucid marginal degeneration. I differentiate between both by topography, of course. Why this differentiation? Because in PMD, there are two things. The first one is it is progressive regardless of age, so we have to stabilize it. If the patient is above 40 or less than 40, above 50, we have to stabilize it because it is progressive, not like the keratoconus. And the other point is, usually the very center of the, let's say, the 3 to 4 millimeters of the center of the cornea, it is regular astigmatism, actually, or half regular astigmatism, because usually the pathology is in the very inferior part of the cornea. So in many cases, we can use the toric lenses with the PMD, and the patient can get very good results. Now, regarding the keratoconus, if it is with opacity, as Dr. Sandeep said, we have to address the opacity based on its density and so on. Now, if the cornea is, if the keratoconus is progressive, we have to do cross-linking. If it is a mild to moderate case, we can go for rings or topo-guided treatment. If it is very advanced and thin, then we can go for the deep lamellar keratoplasty. Now, how to determine the K readings? It's very difficult, actually. And maybe you are asking about the formulas that should be used. Yes. Actually, we cannot say that there is a very specific formula that can give you the IOL calculation in the case of keratoconus. We have to go for more than one formula, okay? And then, of course, we have to counseling the patient and telling the patient that it is an estimation rather than calculation of the IOL. So it is an estimation, and maybe there will be some mistakes in the calculation. Personally, even in keratoconus with irregular astigmatism, sometimes we can implant toric IOLs just in case the patient has corrected visual acuity, acceptable corrected visual acuity, which is above, like for example, 0.7. And there is a reasonable difference between the corrected and uncorrected visual acuity. For example, if the uncorrected visual acuity is 0.2, while the corrected visual acuity is 0.8, so it is reasonable difference so that the patient can get benefit from implanting toric IOL, even with although the astigmatism is irregular. These are my points.
There is one thing regarding calculation of IOL power in keratoconus. There is a formula which is been given by Barrett, which is Barrett's True K.
Yes.
I think you can use that. It's available online, and then you can just put the information and you can go ahead and get the calculation. So it's a one helpful tool. But Mohammed, we cannot hear you.
I'm sorry, I was mute. Osama, if you have any
The one thing which I haven't used it, but some people reported that they could use aura to do the refraction just after the cataract removal, and that can help you in these cases like post LASIK or keratoconus. So that can help you to get better biometric IOL calculation for this patient.
There is a formula as well, which is very beneficial in keratoconus. It is Kane IOL formula, K-A-N-E, Kane formula. It is available on as well on the internet. So you just input the numbers and you can get. So it's recommended to use more than one formula, then you can decide.
Okay, there is any comment from Dr. Fogla, Dr. Muhammad, Dr. Ali?
Keratoconus mostly in young patients, so very rarely do I come across a patient with a cataract requiring, with keratoconus requiring cataract surgery. As Mazen mentioned out that, yes, we do see patients with pellucid marginal degeneration who come with cataract. So these are patients who have had this ectasia for a long time and they were seeing well beforehand. So, if they had good vision for several years, then there is no need to go ahead and do several corneal procedures. If you just remove the cataract, they are well adapted to the astigmatism that's been present, and you will be surprised that they are very happy with the outcome. Sometimes the surgeon is more symptomatic than the patient.
Yeah, actually, we usually see keratoconus patients, young keratoconus patients, having cataract because of the long use of steroids. They have maybe previous vernal keratoconjunctivitis. They have been using a lot of steroids, and from time to time, we encounter patients with cataract as well, young patients.
Dr. Muhammad, Dr. Ali?
I have a comment.
Okay.
Sometimes patients are reluctant to do any corneal transplant, and they have significant or visually significant cataract. And we can always do cataract surgery and do the IOL calculation suitable to their existing corneas. And then, for example, 2 months ago, I did a patient who has been young to everywhere. And then we did just his cataract surgery, and he became extremely happy patient, especially if he doesn't have a lot of comas and everything. And you can always do keratoplasties later. You can always add some IOLs later and so on. So do the minimum for him and then reassess him and evaluate him in the future. If he's happy and he has good vision, or at least reasonably good vision that is satisfying him, do cataract surgery.
Okay, Osama, do you have any topic that we can discuss before? We have 9 minutes.
I think Sandeep will talking about post LASIK.
Post LASIK. Okay.
Post LASIK K for cataract surgery when patient had previous LASIK surgery.
Oh yeah, just the calculation of IOL power. Do we have time for that?
Just give a summary.
Very brief. We need summary only. The last slide. Just show us the last slide.
Okay, let me just try and open the thing. Let's see. Okay, so can you see the slides now?
Yes.
Yeah.
Okay, so we have these three different scenarios, basically post-myopic cornea topography, then post-hyperopic LASIK, and radial keratotomy patients. So all of these, basically the big problem is they all have various degrees of higher order aberrations, and the problem is calculating IOL power and then getting the correct power. If you see, the basic problem is that all of them change the anterior curvature of the eye. And we know that the static formulas which we have, all the regression formulas, they depend on the K readings, the actual length, and the effective ELP, or the effective lens position. So they all change, but there are a few other factors like the tear film. If you have a patient who has LASIK, there will be epithelial changes over time. And of course, there are other factors like biomechanical stability. So what we do is we try and use the there are so many formulas available on the net, but probably the best guideline to use is the ASCRS formula, which is available like this. It's available online, it's free. You can choose either prior myopic LASIK, prior hyperopic LASIK, prior RK, and then just fill up the details what's asked for. And you will get multiple formulas output. So you get 3 or 4 IOL calculations in different formulas, and then you can choose the average of these and go ahead and implant the IOL. The problem is that even with these formulas, you may just get to about 80% of patients who will be within plus minus 1 diopter of emetropia. So you can still have patients with +1 or -1. One of the advantages now with the newer machines is the IOL Master 700, which has got the true K. So it measures the anterior keratometry reading with the help of the telecentric keratometer. And the posterior curvature of the cornea is measured with a swift source OCT. And these two are combined to get a true K. And the results are very, very predictable in most of the cases. And we can use the Barrett's universal formula or the Haigis formula and get, and I'm using this. The main thing is that try and stay a little bit myopic in most of the cases, because the assessment of K reading in these post LASIK patients are always underestimated. So you tend to go hyperopic if you are not careful. So try and implant a lens with a little bit of 0.5 to 0.75 myopic. You tend to be more accurate. And this is the Barrett's True K formula, especially for post keratoplasty patients. It's quite useful. I think the idea of choosing an IOL formula for patients with refractive surgery is a very tricky business. And the patients have to be explained even with lots of effort, and you can still not reach the destination. So one of the things which I avoid, I don't know, people sometimes they do, is not to choose premium IOLs in these cases, and not to put multifocal IOLs in post refractive patients. And if you are going to put multifocal lenses, I think you should have enough corneal tissue to do a re-ablation in these patients if you have missed the target. So that's it from my side.
I have a comment, please.
Yeah.
Okay, Sama, you can go. Okay. Mazen, yeah, Mazen, go.
Yeah.
Sama, he will manage. Okay.
Yeah,
Sama.
thank you. Actually,
Sama, mute yourself, please.
Okay, actually, regarding using premium lenses after laser-based refractive surgery, let's say, I don't have an experience, but actually what I read in articles, I saw some videos, I asked some colleagues who have some experience, they claim that using the EDOF, the diffractive EDOF, it can be used, this type with the post-hyperopic and post-myopic, in spite of the high-order aberrations and the high spherical aberrations those patients are suffering from. So, but not the trifocal and not the multifocal, just the diffractive EDOF. Even the diffractive EDOF can be used in like mild irregular corneas. So I would like to hear the opinion of the colleagues, the panelists, if anybody has an experience in this particular issue.
So can I comment?
Yes, Dr. Muhammad.
Okay, now as for the EDOFs, there are 2 different types of EDOF, the diffractive EDOF, like the Symphony, and the double aspheric, which is double spherical aberration EDOFs, like the Miniwell. I think the double aspheric ones, they work much better after refractive surgery. I have implanted trifocal intraocular lenses, not the bifocal ones, but the trifocal ones, post-refractive surgery, and I honestly didn't find any problem at all provided that the patient has a regular cornea and does not have very high, higher order aberrations. Actually, the trifocal intraocular lens is very good in these patients, because if you end up with a hyperopic result, if, for example, the formula doesn't work and you end up with a hyperopic result, like when we use sometimes the monofocal lenses, it's very forgiving because you have a near focus as well. So these patients are able to see far much better than when you put a monofocal lens and you end up with a hyperopic result. The experience that we used to have, I think this translates from the days that we used to use bifocal lenses, which we called at the time multifocal lenses, but these were bifocal lenses, like the Restore, Resume, and the Generation. I think trifocal lenses can be used if the patient has a regular cornea and doesn't have an extreme amount of higher order aberrations. The other thing is, if you use an EDOF lens, I had the same feeling theoretically. I never used a Symphony lens, but then I talked with someone who had a large cohort, a Jordanian colleague who had a large cohort of the Symphony lens, which is an EDOF diffractive lens, and he told me that he stopped doing that because the patients were not that satisfied. There has been reports using the Miniwell lens, and the Miniwell lens works totally different. We are going to have the Vivity and the iHands, and I think these monofocal enhanced monofocal lenses will have a very good role in these patients as well.
Dr. Mohammed, let's stay on this point, Dr. Mohammed Husni. Now, the patient post-LASIK or post-PRK, they already have high order aberrations on account of the spherical aberration, okay? Assuming that the optical zone is central. All right. So you mean that you can use trifocal in those patients, right? Yes. Yeah. Okay. Now the second point, we know that there are mainly two types of the trifocal based on the central clear zone and the number of the rings, right? Did you find any difference between these two in such patients? Because, you know, there is a difference between the two types and the number of rings and you know, and the how wide the zone is and so on. Please comment on this.
Yeah. Now, I totally understand the question, but the honest answer is I do not have two cohorts that I can compare. The thing is, we started using the trifocal lens, the Physiol trifocal lens, because it has been around for quite some time before the PanOptics came. So I do not have patients that did refractive surgery and that I have implanted PanOptics in. But the patients that I'm talking about, they are only like 4 or 5 patients. They're not a big cohort. And these patients that I really evaluated very, very cautiously and meticulously before putting in the trifocal lens. And I didn't find any complaints, any statistically significant. I warned them. I had a very good counseling time with them. But after I implanted the lens, I found them as equal as any other patient that you put trifocal lenses in, honestly.
Okay. There is any questions? Yeah.
Yeah, there's one comment, Dr. Mazin, regarding your spherical aberration. There is an article by Professor Warren Hill, and he has done some study on this. He says that if patients who have post-myopic LASIK patients who actually go into a positive spherical aberration after LASIK, if you use a lens with a negative spherical aberration, for example, aspheric IOL like IQ lens, they actually do better. But I really don't know whether there's any study about this multifocal lens. And similarly, like post-hyperopic patients, he suggests that those cases you use like Boston long lenses, they do better. And I think this study has been published in American Journal of Ophthalmology.
This is common knowledge, even not after refractive surgery. If you find a patient that has a positive spherical aberration, then you implant a negative spherical aberration lens like the IQ or the Technis. But if you have a patient that does not have that much, especially in hyperprolate corneas like keratoconus or post hyperopic ablation, then avoid these lenses as much as you can, because you're not serving the patient that well. He will end up with a massive amount of negative spherical aberration. This makes sense, but I'm not aware of any study that has been published regarding multifocal intraocular lenses in these patients.
Very good point that you highlighted, Dr. Sandeep. Actually, I made an algorithm. I called it the practical subjective IOL selection, the PSIS, depending on the spherical aberration, depending on whether it is post-myopic, post-hyperopic, or it is version I, and depending on classification of the spherical aberration into 0, into tolerant or tolerable, or non-toxic, or toxic. The tolerable, it is between 0 and 0.35 microns. The non-toxic is between 0.35 and 0.6. And the toxic, it is more than 0.6. Now, the toxic and non-toxic is in terms of neural adaptation. Actually, in general, there are general rules for maintaining the depth of focus that such patients may have naturally, because people having the non-toxic spherical aberration, either positive or negative, such as after hypermetropia treatment or after myopia treatment. Of course, after the myopia, it is positive. After the hyperopia, it is negative. So those people, if they demand keeping the depth of focus, so we have to keep it by implanting the zero spherical aberration IOLs. And if they are looking for quality of vision on account of depth of focus, then we have to neutralize what they have. How we neutralize those having positive spherical aberration, then we have to implant the minus 0.20 or the minus 0.27 spherical aberration lenses. And those having the negative, then like after hypermetropia, then we can implant those old spheric IOLs, those old days spheric IOLs, because they have the positive. They provide almost a plus 0.14 microns to neutralize that one. So thank you for highlighting this, and I can share this algorithm with you if you like, with a panelist to see your comments later, maybe in another session.
Okay, thank you, Dr. Mazen. Dr. Osama, if you have any comments before we close, because we already passed the time, and I think in India it is now midnight. Yeah. Dr. Fogla, I think he is already, sorry, we keep him.
No, thank you very much. It was very interesting discussion, and thank you for all the speaker and for give us their experience, they give us their time to present their cases and to have this nice discussion.
We are late for Dr. Fogla, maybe 1 o'clock?
Yes.
Yeah. Thank you very much for all. Actually, it was great to have you all. Dr. Ali, Dr. Muhammad, Dr. Dibak, Dr. Fogla, and Dr. Khudair, Dr. Mazen, Dr. Osama. All of you, thank you for your time sharing with us your experience. And I hope that we didn't delay you much. I think Dr. Fogla already left us because he is already midnight, 12 something. So thank you for all. And thanks also for the Allergan for sponsoring this meeting. And also thanks for the Marvision for supporting us as a team management. And we hope to see you, actually, all of you in our conference. It will be on 17, 18, and 19 of September. By the way, Dr. Ali, he didn't respond to me. I spoke to him. I sent him several times, but unfortunately, Dr. Ali Rajhi all the time, is more busy. But maybe we can have him in the panel or in the moderating rather than as speakers. Thank you for all of you, and we hope to see you, inshallah, in the conference. It will be very interesting. We are having a lot of international speakers, many sessions. That was also helped by Dr. Safar Al-Bayati. Very thanks to him, especially in refractive and cataract, also Dr. Osama and Dr. Mazen. And thank you very much and good night. See you all. Assalamu alaikum.
Thank you. Good night, everyone. Take care.